Hi, my name is Autumn Sanderson, and this is the end of my part 5 of my presentation to prone positioning and the ARDSnet protocol. As you can see here, I am demonstrating what it's like to have a patient on a ventilator who I need to prone. I went ahead and I put up one of the bed rails, put the bed rail up on the side that I am not standing on because I do not have anybody over there. In an ideal clinical setting, I would have multiple people helping me flip. I went ahead and I am rolling the sheets or blanket below our patient, and I'm about to flip her. Her arms are down by her sides. Throughout the flipping process, I'm making sure that her head is comfortably positioned. I am putting her in the swimmer's position. And for my patient safety, I'm also going to lift up the bedside rail. And after this, I would go ahead and make sure that her airway is secured. I would then check her SATs and her ventilator just to make sure we don't have any disconnections, that my patient's hemodynamically stable, and that she is comfortable so that we can prevent any skin breakdown or any other complications that might arise. And this is part 6, the last part to my prone positioning and ARDSnet protocol presentation for respiratory 2480. And in this section, we are going to summarize what we have already discussed. We started off this presentation reviewing the pulmonary circulation. And again, I just want to preface how important this is for overall gas exchange. It's really important in our oxygenation and our ventilation and in our perfusion. And because we know how gravity works um, in correlation to our blood flow, especially in our lungs, we know that it's even more difficult for our patients who have ARDS, who can't really ventilate or oxygenate or perfuse that well. It's important for them to get the proper treatment that they need so that they can. Our pulmonary circulation system is made up of various arteries, veins, and lymphatic drainage systems that help move fluid and blood. And this also plays a big role in our hemodynamics. Acute respiratory distress syndrome is an acute form of respiratory failure that progresses rapidly. It's life-threatening and it comes along with a high mortality rate. And in this disease process, fluid fills the bases of the lungs and compliance is low. It's really difficult for patients to oxygenate and ventilate pretty easily. The patient's probably going to have work of breathing. They might even be cyanotic, tachy, tachypnic, diaphoretic. You're probably going to see some accessory muscle use. Most of the times, these are our patients that look like they are trying to just come up for air after drowning in a pool of water. When it comes to diagnosing and treating ARDS, we want to look at our Berlin definition, which talked about the timing, imaging, and oxygenation. We also talked about the 5 Ps, which include perfusion, positioning, protective lung ventilations, protocol weaning, and prevent complications. And then, of course, throughout this presentation, we've been talking about the benefits of proning. Our ARDSnet protocol lists out initial criteria. Another thing to note is our PF ratio, and that's going to tell us how severe is our patient's ARDS. And our initial setup is going to be pretty important when it comes to basically taking the steps to ensure that our patient is getting the ventilation and the oxygenation that they need. So like anytime we set up a vent, we're going to want to calculate our patient's ideal body weight. And then we're going to use that to get our tidal volume. We're going to take that tidal volume, we're going to times it by 8, we're going to titrate that down if we need to, or titrate it up depending on each patient's situation and how their ABGs look and how they're responding. As far as setting up our frequency, we're going to give them a standard frequency that meets a baseline minute ventilation, and we're going to adjust it as needed. For oxygenation, we could do high PEEP and low FiO2, or we could do low PEEP with a high FiO2. When we prone, we're flipping a patient on their chest or abdomen, and this is effective in decreasing that high mortality rate that comes with ARDS especially. And this is going to improve oxygenation and ventilation because more blood flow is moving. And patients typically have a shorter time spent on the ventilator if they are prone, and this is going to protect our lung from any injuries, and it's going to help increase our volumes and improve atelectasis. So for my reflection, I wanted to talk about a clinical experience that I had with proning a patient. We had a patient who came in with a flu A diagnosis, and he had a sudden severe onset of ARDS. After an ABG, his CO2 we found out was in the 80s, and his PaO2 was below 55, and the monitor was reading his SpO2 in the low 80s. So we put him on the BiPAP, and not only was he severely agitated, he also was not improving at all on his SATs. His SpO2 actually dropped once we put him on the BiPAP to about 75. So at that point, the ICU intensivist came in. She intubated, and we mechanically vented him. We put him on 100% FiO2 and a PEEP of 12. His SpO2 was reading 75 to 80 with no improvement post-intubation. We waited about half an hour. There was still no improvement with his SpO2. At one point, when it did reach down to 75, we did disconnect the vent from the patient's tube, and we manually bagged them, and there was still no improvement. X-ray came in, they took an X-ray, they did confirm good tube placement. However, it did show a whited out left lung. So we attempted to do good lung down, and there was no SpO2 improvement. So we went ahead and increased our PEEP to 14. Still no improvement, but this time, after we increased the PEEP, we had an adverse reaction shown on the monitor with the patient's blood pressure. And that was when we recommended proning the patient. And there was no initial changes in his SATs once we proned him, but he was not desatting at all. He was just riding it out between 75 and 80. And after about 2 hours, his SpO2 was showing 94%, which was incredible. I also listened to his lungs, and he sounded noticeably better. Not great, of course, but before he was very hoarse, and it seemed like we had a lot more airflow moving throughout those lungs once we flipped him. He was also pulling better tidal volumes as well. So, in conclusion, I do think that proning is a great option for patients who could benefit but have no contraindications. I have not seen proning very often in my clinical experience. I hear people talking about it all the time when they refer to the COVID-19 pandemic. And patients who we do consider proning, more often than not, they're not proned due to some sort of contraindication. Some important takeaways that I took just through my own research is, of course, how important it is to protect the airway. Keeping the skin clean and dry, especially if you're going to have that patient prone for up to 16 hours a day for multiple days, we want to make sure that we're not causing any more harm than the patient is already experiencing. So we need to keep their skin protected so we don't cause any sores or breakdown. Closely monitoring the patient and sticking to a schedule is so important, and it's really a team effort, especially when you are a therapist who has a heavy workload. It's going to be pertinent that not only the nurses and the other healthcare staff assigned to your patient are helping you monitor your patient, but it's also important that your respiratory staff is aware of your checklist and your schedule and what's going on with that patient as well. Because more hands when it comes to proning a patient is going to be better than less. And here are my citations. I referred to the clinical manifestations textbook a lot, and then our AMP text, the ARDSnet protocol, as well as some other sites which I have listed here. And that is the end of my presentation.